world is going to care managers who are calling patients on behest of practices to get them involved in their health care. So I'm going to also, I think we're also like-minded. I also thought about Field of Dreams. And the thing about Field of Dreams, the movie, is those apparitions knew they were baseball players. They also knew how to run, hit, and field. Our cancer survivors know they are cancer survivors. Well, they know they're cancer patients. They don't have the tools to be a survivor. That's what we have to do. We have to help them with the tools. I think that's what all of us are doing on this panel today. I also have a wish list. As part of our pre-conference talk, one of the people on the talk said, be bold. Well, if you know me, I really don't need that encouragement. And that is in terms of survivorship plans, we can talk about them all they want. But if anyone here is on the Commission on Cancer, you can't limit it to 75% of programs. You have to make it 100%. I don't even know how you enforce 75%. So please change that. I'm going to be talking a little bit about the primary care chart to anyone who will listen. And thankfully, the people at JAMA Oncology understand the merit to this. So I encourage you to read that article when it comes out in the next few months. Back at the Primary Care Cancer Survivorship Program conference that was in San Diego in January, I had brought up to the members of ASCO, ACP, and AAFP about having a position paper about improving the cancer patient's chart in primary care. I really think we should revisit that. I should not, I don't know how we move forward in caring for our cancer survivors if we don't have a strong primary care chart. That's a living document. That's not part of just patient documents where all of these other survivorship plans are going to go in the electronic health record and will never be referenced again unless they're part of every encounter. Educating our survivors and our community is very important. I won't go into detail further about that, but I do think that major centers really need to go on the road, like David's mobile unit, in that go out to your communities that are funding you and do educational forums. Help them with survivorship. You know, there's a great series, the GW e-learning series, and it's wonderful, but I don't think anyone's reading it. We have to find ways to get people to look at that are primary care docs. I'm part of a developing fledgling primary care initiative with Larissa Nekliudov in terms of we want to go out and develop a type of speakers bureau where we talk about cancer survivorship in communities where it's not happening. So again, we're looking for funding for that. You find us and we'll gladly take the money. And then, you know, something I've learned in this talk, in this two-day conference, is that there are bridges. I've always thought of myself as a bridge in terms of survivorship, where I'm a doc, I'm a survivor. I understand the angst of the advocates and the survivors. I understand that. I understand the limitations of the doctors. I think that we need to maybe find a way to get the people who are the bridges together. I think we could jumpstart this even further because we've lived it. I've lived it. I know what works, I know what doesn't work, and I can't be the only one. And then the last part of this is I titled Get Me in the Room, and that is there are a lot of wonderful organizations from the Moonshot program to all these different cancer fundraising entities. Don't stop fundraising, but remember that if we cured cancer today, there would still be 16 million survivors that need to be cared for. And while many of them don't have a caregiver, many of them have more than one caregiver. So really, exponentially, it's not a stretch to say that there are 40 or 50 million people affected in survivorship. And we have to, with David's help, implement ways to make it better. Thank you.
So now we'll take questions. Great. Good morning, everyone. I'm Rebecca Shearer with LiveStrong, and I oversee our health systems and strategy. Can you hear me okay? And so I think the call to action has been put out extensively over the last 2 days. We heard this is the Just Do It session, many Field of Dreams ideas. Yesterday, Dave said, we can do better, and Julia said, who's ready to make a commitment? And so I have a quick comment and then a question to all of you. So they're coming right now in Austin, and we are just starting to build it. That is our problem. We are in the process of co-creating a new model of care with patients and community members. And it's building on all of the incredible work that many of you have been doing over the years and what we've learned from the work from the Survivorship Centers of Excellence and all of our research and our patient-centered research over the years. But essentially, we have an opportunity through a partnership with the new Dell Medical School, which is being built at UT Austin, to create an entirely new model from the ground up, from zero, completely unencumbered. And so right now we're in dream mode. If we can dream it, we're going to figure out how to fund it later. But it's based on human-centered design plus evidence-based practices, high focus on innovation, and then also looking at the values of patients. So we're working with these experts who are experts in patient-centered value, and we're going to be measuring everything and our success and our outcomes based on what we're calling the 3 C's. So patients value capability, comfort, and calm. So including many of the problems that we have seen yesterday, we're trying to build in solutions for many of the things that we've been hearing about, making this a relational wraparound model of care with comprehensive patient and caregiver support through a robust, really broad-based team, empathic whole person care, technology, telemedicine, PROs in real times, using wearables to track PROs, coordinated care with PCPs from the moment of diagnosis, palliative care and symptom management from the moment of diagnosis, and then wrapping around care for caregivers entirely. They get their own plan and their own people, and then focusing on reducing financial toxicity. So my question to all of you is, we're right now in the strategic phase of building the DREAM program based on all of these gaps that we've heard. So what we've heard in the last 2 days is the foundational pieces. What I want to know from all of you is, what's blue sky? If you could build the DREAM program, what are the things that you would include, aside from all these foundational things that we've been hearing about?
I'll respond. We've been developing our survivorship program for the last 5 years, and I'm impressed that we leave so much behavioral and mental health out of healthcare. So my dream would be to have mental health integrated into primary care, integrated into specialty care, into the hospitals, to have bigger palliative care services, bigger psychiatry liaison services, and easy access to psychology care for the cognitive behavioral therapy that can be so helpful to our patients, but it's just so hard to get.
I actually thought about this. I think I talked to somebody about this yesterday. And that is, the first and foremost thing is we need a national mechanism to get the word out that survivorship is a thing. If we don't do that first, we can build whatever we want, but we've got to do that first. And that's for survivors, that's for oncologists, that's for primary care docs, that's for hospital administrators, the gamut. So we need to have a national awareness program. I have a couple of vignettes that I've told to different people. I'm not going to go into it now, but that's the first thing. The second thing, and that's part of education. So we have to develop education about survivorship. So people have mentioned it before about getting into the medical schools, getting into the nursing schools in terms of survivorship awareness in those areas, because that's how you also build your workforce. So that's one thing you have to do. You then need to get out into the communities. Get this away. I'm sorry, I know you're developing it in a major institution, but we need to, you can do two things. You can do it in the major institution, but you then have to partner with other areas outside of the silo. The other thing is you could start in the communities and maybe go in the reverse.
That's exactly what we're doing.
Right.
Yeah.
Start in the community, then go to the silo. And you then, that's just a few things, but at the bottom line is, this is not a Monday to Friday job. This is 24/7, and you have to find passionate people.
Our most popular programs are integrative, so yoga is something that almost all can come to because it's restorative yoga, and there's many places that patients can't go to. The other thing is a practical classroom with cooking abilities. People really like coming and seeing demonstrations with video capabilities so we can do outlying areas. We also have a survivorship park that we're building in the middle of our city that messages those people that are walking through the park downtown on what's going on, and we're holding classes down there as well as in our cancer center. And nutrition is our number one, and we don't have any charge to any of our nutrition classes. That's our number one thing in demand.
I was just going to say engaging patients fully. Health Canada has a patient engagement kind of ladder. I don't know if you're familiar with it, but engage patients all the way up to the highest levels of planning and design from the very beginning, from the ground up. I think that's really important. And the other thing is, and I meant to say this before, but Dr. Argenbright reminded me that, I don't know, the look on your face at one point was really made me feel a great deal of compassion for asking questions about what people need, getting answers, and then realizing that the fiscal infrastructure of healthcare does not necessarily facilitate meeting those needs. And so the thing I would say is, we absolutely, at this point, in that sense, survivorship care well done is the tail wagging the dog. And we have to hit the dog on the head and make it go with the tail, And I think that means being intentional at the beginning about ensuring that the resources are committed to this, because if we build it, we will come. And we will have needs. As Dr. Argenbright, the look on his face showed me that he's a man who lives in terror of not meeting the needs he asks about. And that's a real problem.
So just a real quick thing, I guess somehow we've got advertising slogans in mind at various points. So I was thinking about, it's been said multiple times, the just do it, and I was thinking too often we don't add the word better to it. And I would love to see, again, blue sky, this idea of how can we expect that we should be doing things better over time, that we're not necessarily going to get there on day one. And I think from the examples that were earlier in this panel, I think we saw opportunities to refine and to improve, but not necessarily all programs are built with this idea that we're going to try to do better. We're going to try to learn from our experience, and we're going to identify where strengths can be strengthened further, where challenges can actually be addressed. And it would be really wonderful to be thinking about building a program with that in mind from the get-go.
Hi. First, Mary, thanks for the shout out to e-patients. I wasn't in the room at that time, but I heard it on the live stream on the sidewalk coming here. So I'm so glad there was discussion of dissemination science. The huge flaw in terms of how things actually reach frontline reality that I hear about from all kinds of patients who are in the crucible is, it was identified in that one great statement. The first step is the decision to adopt. And a real problem, I said yesterday, you know, we've got to fix these leaks in new knowledge, reaching the point of need. Remember drunk driving? It used to be that we wouldn't bust judges or mayors or whatever who were drunk drivers, even though they kept causing harm. And then it became not okay to be somebody who kills somebody that way. What can we do? And I know this is a tough social question. What can we do to solve the problem of doctors who say, as some have said to me, I want the freedom, I want the autonomy to practice medicine as I see fit. I don't want to be told by some paper in a publication. What can we do to make it not okay for doctors to forcibly be out of date?
That may actually be the topic of an entire panel discussion on
I'm
terms
in.
of accreditation and standardization and changes in healthcare delivery, both on the professional level and the systems level. But I don't know if anybody wants to comment.
I'll just comment. I'm a medical oncologist in practice for 30 years doing general medical oncology, and I see the field evolving toward subspecialties within medical oncology. So you have hematologic malignancy medical oncologists, you have breast cancer medical oncologists, you have brain tumor medical oncologists, and even those are subdividing further. So the growth is staggering that's going on, and I think we're going to see more and more subdividing where oncologists pick out areas, and we have more kind of specialty clinics, and they will be a reference maybe to general oncologists who don't have access to that. But more and more we're developing, and we need ways of getting that specialty knowledge to the frontline oncologists who just can't possibly keep up with the fast flow of information.
Just to be clear, I didn't mean people who can't keep up. I mean people who explicitly don't want to.
Well, and just for maybe a different survivor viewpoint, I actually really want my clinicians to have autonomy. I want them to be in discussion with me about what facts are known, and I, of course, nothing about me without me. They're not going to, if they're going to insist on treating me in a way that is neither evidence-based nor makes any sense to me, then I'm going to walk somewhere else. But I do want them, I don't want to sacrifice autonomy for the sake of that.
I'm sorry, Regina, I called you Mary. I'm sorry.
So I teach in our medical school, and I am continued to be awed by the medical students who are coming into medical school now, who get it a lot much better than my generation did. They're much more excited. They're much more team-based. I've got a lot of confidence in them.
I notice there is no answer. I mean, there really isn't.
Thank you. My name is Tina Evans, and I am so many of you in the room, a survivor as well. And as a result of that, I had been in nursing, and then I became an oncology nurse navigator, and I've been doing that work for 15 years. And I have so many things I want to say that I hope I stay coherent here. At any rate, one of the things is I'd like to say thank you to everyone in the room who has contributed, and especially all of you who I read your research and I follow the literature religiously around oncology care, navigation, survivorship care, and I feel very privileged to be in this room yesterday and today. And thank you for what you bring to this forum, because you really do inform policy. And I feel very privileged to have been witness to that yesterday and today. So having said that, I have a couple of comments and then I have a question. And the comments are really about the survivorship care plan process and survivorship care. And in my work that I've been doing for a number of years now, I've had the opportunity to network with navigators and navigation programs and managers and administrators nationally. And in my current work, I do that every single day. And what I hear so often is what the immense struggles are with the survivorship care plan itself, the document. When we've been acknowledging this morning, and I'm so grateful to hear that it isn't the document, it's the process, and it's the care, survivorship care. So I hear day in and day out, how do I create this document? Where do I find the time and the resources to create the document? And how do I make sure that I meet the accreditation standards? And it isn't about those numbers. It's about the process and moving forward with survivorship delivery care and awareness of what we need to do for this growing survivorship population. So having said that, one thing that always bubbles up to the top for me in this conversation is, let's not focus so much on the numbers and the mandate to reach a percentage. Let's focus on where that is going to get us with communicating and caring for the survivorship population. And I do believe that there are enough high-level stakeholders in this room that I would challenge that we try and move that forward versus worrying about whether we're being compliant with 25, 50, or 75%, and losing focus of what we'd really want that work to be doing with our survivor population. So I do have a question around that, but before I ask my question, I also want to say that I thank those of you this morning who have acknowledged the value of navigation in oncology care. I think nurse navigators and the navigation team hold so many of the answers to our fractured system of healthcare, and that I know there's another forum like this in the fall that's going to be addressing patient navigation once again. And I'm going to try my hardest to be here for that, because I think it's a critically important topic. So thank those of you who are continually supporting the navigation paradigm. So my question is, and I've asked this, but I've not gotten many answers because I don't think people really want to hear it. So we have this whole idea around a survivorship care plan that we struggle so hard to get into the hands of our survivor patient population. And sometimes we are successful actually getting the document in their hands, and sometimes we're not. And my question is, where is the research, or is it coming along, or is there evidence at this point that an actual document itself influences outcomes? I look through all the time. I'm looking for literature that I'm looking for evidence that that document itself influences outcomes. If not, are we working on it? Are we trying to gather that evidence? Where are we with that? And then I just have one more comment to make, but that's a very basic primary question that I can't find any answers to.
I will try to answer the question. So as a clinician developing survivorship care plans, I've asked the same question, and there's really scant evidence that the document itself makes a difference. What the document does do is to serve as a documentation of a process that occurred. And that process is what's so important. And we have a love-hate relationship with the accreditation standard. On one hand, it's what got the hospital to fund the survivorship program to make everything we do possible. On the other hand, it is a lot of bureaucratic jumping through hoops and a lot of minutia with the electronic medical record. And it's just a complicated world we live in.
And again, you know that I work a lot with the underserved and the uninsured, and we use survivorship care plans, and we find them to be very important. But you've also got to understand that in that particular population, the survivorship care plan is a menu of services that you need that you can't access or afford. And we're laying that all out there to say, these are all the things you should be doing that you have no hope of ever getting to. And so to your point about navigation, you have to be able to marry that survivorship care plan with an active navigation to be able to get the patient to those services, or otherwise none of it makes a difference.
So we're running out of time. Oh,
I just want to speak to that. I'm going to respond in many different ways. First is, I respectfully disagree with you. I think the percentage should be 100%, and I'll tell you why. If you look at 99.99% of the primary care doctor charts in our country that have to do with cancer survivors, and let's say you're talking about a patient that has lymphoma, the only thing the chart may say is history of lymphoma. That's all it says. So I go into it in this piece in JAMA Oncology about that. The only way to make that change, and it goes to Dave's question as well, is that one, you have to communicate the information. I'm old enough to remember getting oncology notes on patients that are this high. So the survivorship care, and having to go through them and not understanding handwriting or whatever to try to figure out something about what that care was. So while the survivorship care plan may not be the all to end all, it's a start. And it provides information and communication from the treating oncologist to the practitioner. Now, the problem which I've
Jay,
only touched on a little bit.
Jay, we do need to watch our time. We're actually out of time.
The problem that is that how is that practitioner going to utilize that information? And that's something we haven't really touched on a whole lot. And to just speak to Dave's point, unfortunately, the only way things get done with doctors is making mandates and tying them into reimbursement. That's the only way it happens.
Okay, we're going to go over time just because there's so many people with questions, and take one last question, and then I'd invite other individuals to come up here to the panel while we have our break.
Thank you. It'll be a brief question. I'm Ron Klein, I'm from CMS. I'm going to fulfill my designated role as a pediatric hematologist oncologist. There was a previous IOM workshop where we looked at the very, very small number of pediatric cancer survivors and the number of years they would be alive because they had cancer as children, and the very, very large number of other folks, of adults who had cancer, and the number of years or less because they're older. And I mean, nobody's done the calculation, but if you sort of look at number of years of life, you know, there's a significant number of years of life of pediatric cancer survivors. So the question, and I commend Doctors Argenbright and O'Rourke and Burton for the work they're doing. The question I have is, does your survivorship, and I'm sorry, I forgot your name, Franco? Sorry about that. I commend the work you guys are doing and the heavy lift you guys have done. And the question is, do you include adult survivors of pediatric cancer? And if not, why not?
We certainly do. It wasn't appropriate to have 35-year-olds go to pediatric survivorship clinics. And we had to change some of the things we're doing because they are a different constituency with regard to their cancers and even their needs. And so we have a lifetime clinic for those. And as well as our transplant patients have very different needs as well. We didn't really go into that as well. And then, of course, our AYAs, which are the 15 to 38 year group. Again, very individualized needs, but we need to individualize them according to those subgroups.
And likewise, we're very fortunate that we have a very active AYA coalition in the North Texas area. It's headed by a pediatric oncologist, Karen Albritton, who just does wonderful work. The great thing is that we're able to kind of be that neutral site, because a lot of the cancer patients, as they transition from pediatric to adult, are looking for a neutral site, and so we're privileged to be able to fulfill that need as well.
Just a quick point on that. There is a handoff, though. So we have done this handoff with the pediatric group coming up to the adult group, because these people are complicated and they often don't know us. So that has really worked well as do some type of formalized handoff.
We also, just this past month, have started the process of developing a young adult group as in our community.
Thank you. My heart has a smile on it.
Well, on that positive note, it's time for a break, but I'd like to thank our panel and all the speakers and discussants.